these are my disclosures. So heavy calcium remains a drawback in endovascular therapy. It makes stents fracture, even special designed stents not to fracture, as you can see in these results. And I was here when the impact SFA study results were shown, and there was a very enthusiastic response to that. Like, this is a first-line therapy for SFA disease, and Menke, a publicist from San Francisco, said like 100 years ago, to every complex problem there's a simple and neat answer that is always wrong. So I think we need a differentiated approach to what kind of lesion we treat. And there is not one answer for everything. And you see here that for impact SFA, there were only claudicants and rest pain, and patients like this granny with the walking aid would have been excluded, as would have been patients with severe calcifications. So everybody knows this slide from Finelli, who did a subgroup analysis on DCB outcome graded on a calcification scale based on CT angiography. And you see the more calcium you have in the wall, the less good DCBs perform as a standalone therapy. So, and what we saw from the poll just now is that the majority of you believe in vessel preparation in calcium before applying the DCB. So how should we treat these vessel bones? Here you see directional athemectomy specimen, and in fact, lipid pool plaque can transform to bone. I saw Professor Ramani here, so this is bone tissue in the vessel wall. You see it on OCT, and you see it on the histology specimen. I want to share some cases with you. This is a patient who received for abdominal angina stent, and the stent would not open completely because the vessel balloon ruptured at 24 atmospheres. So you cannot leave that like that. This is actually aortic calcium in the aortic wall. So here we went in with a 6x60 shockwave catheter and did 4 inflation, 120 impulses, and then suddenly the lesion popped open. Here you see the result of the then finally open stent which opened at 8 atmospheres. Here you see a patient with a lesion that surely calls for surgery, but the patient didn't want to. He just changed his job and was fearing to be off job for some time, but he seek treatment. So here we treated the SFA with lithoplasty with a quite convincing result. And then we went for the common femoral. And you see there is a huge reduction in stenosis. And clinically, the patient profited enormously with enhance of the walking distance from 50 meters to more than 500 meters in treadmill testing. Here you see a completely different case, a patient receiving BVAR. And you see that the via band landing in the celiac trunk is narrowed because of aortic calcium. And we went in there with a high pressure balloon up to 25 atmosphere, and the lesion would just not respond. And here you see a lithoplasty catheter in place with the shocks applied, and we delivered all 180 pulses, 6 inflations, and then with the very last inflation, we go up to 8 atmospheres, and suddenly you see at a relatively low pressure here how that calcium moves aside and the stent is completely opened. And it is not that I start in the morning like, where can I use leg technology in different places. It's just, this stent would not open at 25 atmospheres, and then you have to deal with it and find a way to help the patient and make your implant work. So this is about real-world experience. I put for you this case I did together with my friend Theo live at this meeting. A rock-like calcified vessel. It was a kind of vessel where my first mentor told to the patients, like, you could break your legs, sir, and walk on your vessel calcification. And you see bilateral calcium in the wall, like here and here. And you see how much the balloon is wasted at the low atmosphere, and at 4 atmospheres, hitting these lesions with 180 impulses each, we were able to open it and receive this very nice reconstruction you see here in the end. This is a case which I was shared with me by my friend Dr. Bill Miller from Colorado, and I wanted to share it with you. So this is an IVUS control with a relatively and totally undersized balloon in the aorta, and you see the pre-IVUS, pre-treatment IVUS, and here with a 7 mm balloon, this lesion was hit. And this is, you know, after ballooning alone, how much lumen gain you can achieve, and then finally he put a 10 mm stent, helping this patient with chronic rest pain. So I conclude we can treat with these new technologies lesions that are unresponsive to stenting and high-pressure balloon angioplasty. We have acceptable clinical and angiographic outcomes in rock-like calcified CFAs. We have done now 5 cases so far, and I think we're going to team up with Marianne and publish on that. We see early experience show promising results in highly calcified aortic branches, and the device, as Andrew already said, has the potential to make EVA, TEVA, and TAVI feasible in patients with poor iliac access vessels. Thank you for listening.